Hello, everyone, and welcome to another episode of Sarcoma Sisters. Wendy and I are super excited because we have a very special guest today, PT Dan, and PT is for physical therapist. So thank you, Dan, so much for coming. We'll get into all the information about you because he is not only a physical therapist for kids with cancer and sarcoma, but also he has quite an amazing social media presence. So we'll talk about all those things today. So welcome, PT Dan.
Thank you so much for having me. I'm glad to be here.
Awesome. So I'll kick it off with how we've been starting a lot of our podcasts this year, by having you just tell us a little bit about yourself and what got you into physical therapy, and then specifically in this patient population of kids with cancer and sarcomas.
Sounds good. You ready for the Candyland version? Because this is going to be a winding road.
Oh yeah, no, it's
basically, perfect. I started off as pre-med. I was a pre-med undergrad and a psych major, and thought that I guess I was thinking med school. Before that, I was thinking of being an airplane pilot. So let's not read too much into my decision-making capabilities at my early 20s. But it came down to me not really feeling like the medical route was right for me. I was ending my undergrad. I'd shadowed a few places. I had shadowed actually a peds physician, and I didn't really like it. And I thought, well, I got to find something to do while I'm figuring this out, and at least applying to med schools and stuff. And so during that time of uncertainty, I ended up starting a job where I actually work now. I worked for a specialty clinic that had pediatric oncologists in it, or had two of them. And then I continued kind of interacting with all of their patients, managing schedules and things like that. And then somewhere in the midst of that, I was interacting with kids with cancer. There was a few specific ones, one very specific one who is, I think, seeing me next week in long-term follow-up, but she's like in college and stuff now. It's crazy. But she came out and interacted with me at the front desk and was just, I was wondering what was going on with her. I kept seeing these kids in oncology that were working. They had, braces on their legs and some of them and things like that, things that just didn't seem to be going well. Some of them were in wheelchairs then all of a sudden. And I was sitting there going, what goes on with these kids when they're going through this stuff? Like, what's the fallout from this? And, that led me into my nerdery, my research compunctions. So I started looking up, okay, what are the impairments? What things actually occur with these? Why do they wear braces? What's up with that? And trying to figure out, what sorts of things PTs do for that. And that sort of thing, that's the thing that brought me to PT was actually the oncology world. So I never came into it as an injured athlete. I've never been athletically inclined, and I'm sure I could have incurred an injury, but I just gave up on athletics too early. So I was just the medical nerd who saw something of value that could be maybe delivered to these kids. One of the things I also saw is that they're at the hospital and the clinic all the time. And these are the kids I interacted with the most because they were there the most. So a very hard road for them to take. And so in my mind, I started with looking into this. I had one buddy who was a PTA, physical therapist assistant, and he kind of spurred me on to just keep looking into that. I think you should check into this and stuff. And I was like, well, okay, I'll look into it more. I'm curious about this anyway. And talked with the PT who eventually hired me, who's my manager now. And he said, you gotta, they all encouraged me to look into it and try. And that's where I applied and got into PT school. And I was like, well, this is the road that I shall walk then. And I've never looked back. Honestly, I'm very excited to be where I'm at. And, while I was in school, I knew that that's what I wanted to do. And I think I sucked the air out of a lot of conversations talking to people about kids with cancer and the kinds of things that they have to experience and how they can be helped. So my goal has always been to help kids with cancer rehabilitate and help them read what I always say on my channel and everything else is restore, rebuild, reclaim your world. My hope is for them to have that, maybe to rekindle that desire that says, I want to think about the thing that's coming next and prep for it. And I want to reclaim what I may have lost or what cancer may have tried to steal from me. So these kids think of it, whether, even though it's not academically acceptable to talk about research or talk about pediatric cancer as using war terminology and battle and conflict terminology. That's the way they all think of it, because a lot of them are just angry about the fact that they've lost things.
Yeah.
So it keeps them motivated. And so I did my research when I was in grad school on pediatric cancer rehabilitation and the different impairments and how PTs are involved with those. And did a clinical rotation at St. Jude. They were really nice. I have wonderful things to say about all of my mentors at St. Jude. They taught me so many wonderful things, and I was able to bring that back to the children's hospital where I worked before. And so I continue to plug away here, getting to do lots of weird stuff. I get the stuff that I do is sort of, it fires in the midst of PT, but it's also, I'm like part event planner here sometimes too. When you want to motivate somebody, sometimes it takes big overtures, and I really just want the kids that I work with to look back someday and say, "Huh, he must have cared. That's cool. He must have cared about me." So
that is so amazing. And I think for sure anyone, which we'll definitely link your socials, but anybody who is, it's going to come through, it comes through in what you're saying right now and everything about your caring. I think that's so evident. And I love your story, because I think what you said, a lot of people who go to physical therapy, it's the story of, I got injured and a physical therapist helped me, and then I went into physical therapy, which is for all of our listeners who might not know, the rehabilitation of joints and muscles. And I think that story is so meaningful, that what motivated you is you saw this gap and where we needed to step up in pediatric oncology, and then that's what motivated you to go. Because I think when I was practicing, and Wendy can speak to it too, it's like we so much in patient reported outcomes we need to improve on, because quality of life is so important. And we are so lucky to have so many survivors in pediatric oncology, but then what is their quality of life? And I think physical therapy plays so much into that. And that's why we really were excited and are excited to talk to you more about that today. And that's really, really cool too, that you were able to go to a center to St. Jude and learn more from expert physical therapists that deal with that are able to work with kids with pediatric oncology issues every day. So that is amazing.
I got to prop my jaw up there every single day because I worked with some of the best people, and they still, some of those folks publish such good rehabilitation research. I don't know if you're familiar with Kiri Ness, but she's one of them who's like, she's so stinking smart. And I got to work directly with her when I was there. And so most of the time I was sitting there going, that's Kiri Ness. So some people are into wrestling. I'm apparently into like oncology researchers, I guess.
We feel the same way.
Yeah. I fanboy it up around them. I feel bad, but like, when I print their faces on the t-shirts and stuff, I feel bad, but I do it anyway. So
that's amazing. So, and then I guess, can you tell us about in a typical day, what type of patients you see with what type of oncologic diagnosis, and then kind of how your job is, because, like you mentioned, you're part event planner too, but kind of how it all works for physical therapists in the world of pediatric oncology.
Yeah. So day to day, it's a hodgepodge, a mixed bag. I have a lot of leukemia patients that I see. It's actually, it's very similar to the relative prevalence of the diagnoses that I see. I see probably a few more Wilms tumor than really qualify as being a part of the national average for Wilms, but I do have some Wilms tumor patients that I look after. And who I hope I motivate. And a lot of ALL kids working on neuropathy. And so some of them, earlier on working on some of that steroid induced stuff that happens during induction has been, it's kind of the name of the game here lately. I feel like a lot of people, they're either having steroid induced issues or they're having methotrexate induced toxicity, and lots of different presentations. And yeah, then my sarcoma populations it's been a little bit of everything. I have a lot of kids that have chosen the limb sparing route, some that have chosen that and then ended up having an amputation because of a hardware failure or something like that. A lot of rotationplasty patients, and I think I've had the most rotationplasty. It's neck and neck with amputation right now. They're amazing patients to work with. I know you guys are the sarcoma sisters, so we can stick to sarcomas if you'd really like. But all of them are all of the patients I work with, you see the struggle, but the wonderful thing about working with kids going through cancer treatment, I'm going to try not to cry here. We'll see. But they want so badly for things to be back to normal. And so as a rehab guy, as the PT Dan of the castle, I get to kind of show them either new possibilities or try to reacquaint them with the things that they lost, and to really bring that little piece of their world, the piece of normal, back into the picture and say, hey, look, this is within your grasp. Here's how we get there. And this is what we can do to fix this. And some of them have had drastic changes because of the sarcoma, for instance. One of my dear patients went through a limb sparing procedure, then ultimately had the leg amputated. And it was sort of beyond his control. He said he was glad that happened, because it was beyond his control. He didn't really know what to do. And he was a fierce competitor, really. Just like the joy that I get just talking to people, like even in Costco, is the kind of joy that this kid got competing with people, no matter where they were, no matter who they were. Honestly, like always, petulant. Like he's like, hey, let's do this. How about you want it? Like, I'll bet you I can do this better than you. I'm like, I bet you can every time, man. But I'm like, I'm not coordinated, right? But he taught me so much about the little things that motivated him as we went. And so the funniest thing about him is he loved to compete so much, but he wasn't able to play football anymore, and he wasn't able to really shoot baskets anymore for a while. It's a lot of those movement things became hard while he was going through all these limb differences and changes and stuff. And so what I admire about him is that he stumbled onto something else that he enjoyed. And I never really, I was there when it happened, and I think I was slightly involved because he had challenged me to a push-up contest. Mm-hmm. And it was to be done live on the radio. We had a radiothon that used to take place pre-COVID in the castle, and they'd raise money for the local CMN and the Cure Kids Cancer Foundation here at the facility I work at. So he said, man, I'm challenging you. He's like, this is what I'm just going to quote him. He said, you put me through so much crap. Now it's your turn. He said, he's like, it's push-up contest. We're doing it today. Meet me downstairs, blah, 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 all this stuff. So he was getting interviewed on the radio. And then I came in and we did this push-up contest. And then people started donating money based on the push-ups and in honor of him and things like that. And he's like, they're actually getting more money because of this. And I was like, yeah, you should do this. This should be your thing. And he was like, yeah, this could be my thing. So yeah, we started making this a yearly thing. And so every year we would have try to make a theme, and we'd advertise for it. And so he found a new way to compete. And it was really just competing against, me, but also against himself, and trying to, kind of push himself toward what he could do and to make a difference with it. And I think to a large degree, he changed the world up here.
That's so amazing. That's awesome.
Very cool. So
I have lots of rambling stories, ladies. I'm so sorry.
No, these are great. Everybody, these are amazing stories, and it's why you do what you do,
Yeah.
And you are a part of it for sure. Okay, Wendy, you can ask.
I have two questions.
Yes, ma'am.
The first is, you keep referring to the castle.
Yes. Oh, I could show you, except my background's blurry, but It's Sanford Children's Hospital in Sioux Falls is where I work.
Gotcha.
And I'm very, in case any of them are listening, I'm very proud to work here. I'm very thankful for the opportunity I have, and I thank God for it every day.
Excellent. And then here's my question.
Yeah.
So I also now take more care of more than just sarcoma. So I have my fair share of Wilms and other things. And I have opinions about this, which I can share with you later. But it's a two-part question. One, do you think every child diagnosed with cancer needs a physical therapy evaluation? And two, when I write physical therapy, evaluate, and treat, what do you do?
Oh, sure. Well, let's talk. So
because there's a black box, it just goes
yeah.
up, and then all y'all do your thing, and I want to know what that is.
Some of this might be helpful for me to answer your entire question to satisfy your curiosity if I knew the kind of facility you work at, but perhaps I should talk a bit about the one that I work at. So yes, I do believe where I'm at, it is appropriate for every kid to have a PT evaluation who's going through oncology treatment. We know that this is a population that is, the cure is the predicted outcome because of the 83% survival rate across the board for childhood cancers. However, 85% of them are going to develop a chronic condition by the time they're in their 40s. So because of that, we have the greatest leverage over this problem the earlier we start. And I think that that's borne out in the research related to physical activity habits affecting these kids later in life. And so that's why my major sticking point for this would be, yes, they do need it. It has to be tailored to the kind of treatment they're going to be going through. And it needs to be tailored to each individual child, because no child should be treated exactly like their peers or in some kind of cookie cutter fashion. So each kid is interested in specific things, and each kid is coming from interests in certain things. They've already been in activities or something like that. So trying to reinvent the wheel for every single child, especially like waiting till they're after treatment. Oh, you're done with treatment. Now let's try to get you healthy. Like, it is a very, it's a very hard place to start. No baseline assessment means you have no idea where they should be, given their, the parameters that cancer has put on their life. We need a baseline to know this is where things started. Yeah, they're going to developmentally progress and change as they go through treatment. But I very much believe that if done right, I mean, it should not be a black box, whatever the thing you were talking, like, it should not be a referral into the distance. What I love about the team that I work with and my oncologists and oncology nurse practitioners, they're very, very good at looking ahead with me. Like, I'm not the only one concerned about this child's future. And every single person on my team, not my team, sorry, the team that I'm on, the team that I'm allowed to be the second stringer guy on the bench cheering really loudly from, that guy. I love that they are thinking about these things too. And in long-term follow-up clinic, the nurse practitioner that I work with is tremendous at problem solving and going, hey, this doesn't seem right. I think let's get PT roped into this. And it's part of the natural thought process that we have here. And so I'm so blessed that I get to invest in lots of different types of kids at different stages. And the idea is always learn about, sorry, my finger is disappearing, learn about the child and then figure out how to make their world come back together, to put a broken piece or two back together whenever they really think things are lost, mostly.
I'm muting and unmuting because I have a dog who's barking.
I've got alarm, or not alarms, but like overhead messages going on. So I hope that doesn't come through.
No, it's okay. So one of the things, especially for patients that are diagnosed with sarcoma, one of the things that can be challenging depending on, where they're at in therapy, where they live in relationship to distance to the medical center, et cetera, can be just finding the time to get the evaluation in and then do the actual work of therapy, because some of these programs or some of these protocols are pretty time intensive with inpatient, outpatient. And I hear from my patients sometimes they don't, they have nicknames for you guys. I'm just going to tell you that. And sometimes that work that you're asking them to do, while very necessary, can be very tiring also. And it can be just another thing, a very important thing. But sometimes it feels like it's the easiest thing to go, which is not the right answer. So how do you work with fitting all of the demands of therapy? And I mean, and when I say therapy, I mean treatment, like chemotherapy, surgery, PT,
sure. Yep.
sometimes speech, all of those things. How do you fit it all in to make sure that you're getting what you need, but not pushing them past a point where it's not going to be effective anymore?
I think the best way to approach that, at least the way that I try to approach it, is to it has to be valuable to them. Whatever you're offering them has to be valuable to their world and to the energy level that they have and all that stuff. So generally I tell them, hey, there's going to be days where we do less. There's going to be days where you might not even need to do anything because it just things aren't going great. Or, if they're coming in and they're going to get really nauseated through their chemo, then you try to time it better, and that sort of thing. So the way that it seems to be working, nobody's fired me yet. So anyway, the way it seems to be working so far for me is you have to learn about the patient and learn about what motivates them. Starting there that's the biggest tip-off point to what you can really do with them. Some patients are highly motivated by the chance to move and the chance to feel something normal again. If they are athletic or if they are just sick of in the same four walls of the hospital room or something like that, then making therapy fit their desires for that day helps too. If it's a younger kid, sometimes it's a trip outside, or sometimes, if it's not astonishingly cold out like it is where I live most of the year, but or going someplace that's cool, that okay, we have a gym like on the hospital campus that I can take patients to. Okay, so if they're into that sort of thing. Now the other thing is like making sure that the precautions that they're on, or whatever, if they have a lower extremity sarcoma or something like that, making sure we adhere to all those things in the midst of that. So some of this is a teaching conversation with them, like, hey, remember the thing, what are the things you're supposed to do? What can't you do? Are you allowed to bend it? That kind of thing. Can you put weight through the leg? What are you actually allowed to do? Then the rest of it is chalked up to, hey, these are some things, this is how we stay active in the hospital. This is how we make your admissions shorter, because you're not laying in bed the whole time getting nauseated and sicker. And so let's get up and move a little bit. And then sometimes it's literally just, here's something that's totally different, and let's try this for therapy today. So whenever I feel someone is not into it, then it's my job to figure out how, like, not to force them to like me. If that's, my parents used to tie the beefsteak around my neck and stuff to get the dog to play with me. But now these kids, all I'm trying to do with them is like, okay, you hate just about everything about the hospital. You hate the chemo, you hate the way everything smells or tastes and things like that. So let's go do something that's totally otherworldly. And I've only set off 2 fire alarms coming up with ideas for these things, but throwing things at me has been helpful. Like sometimes you just want to get some anger out. So I've thrown a target onto myself and let them chuck Velcro balls at me and things like that. Like, okay. I mean, I know what I try to circle back to saying, because sometimes they don't do as much as what I maybe had planned that day. That's okay. I'm there to have a plan. I'm not there to dictate what their body has left in it and I always talk about their tank. Like, hey, if your tank is empty, we can be done. Like, it's okay. And my goal is for them to understand that they have an advocate and someone who is going to be bearing some of their burden as they walk through this. So my goal is to uphold them and not to hold them to a certain thing, if that makes sense.
Yeah, absolutely. I think, in a lot of a lot of times you can see a lot of conflict between parents and the patient about expectations about how much should be done or what can be done. And I think recognizing those limitations and, always pushing people to be where they're at, you know, and walking that fine line. It's a balance, and it's the art of what you do. And helping families understand that can be very beneficial, but yet very challenging, because like you said, you don't want their knee to get stuck in a position. You don't want to push it too hard. If their tank is a quarter full that day. And so a lot of times as the physician, people will ask me, well, what do you think? And I'm like, well, I'm going to do whatever PT says. I don't know. I mean, like, we've had zero training in physical therapy, honestly. Well, not Lisa, because Lisa's a DO.
Oh,
so
sure.
You have more experience than me.
Ooh, you can do all the cracking and popping too, then.
Yeah.
Not anymore.
It's hard as MDs, because it's like, we really do need to just lean on you guys and defer to it. And so I see some conflict come up at times. Always during the times where I've made them feel the crappiest because of whatever we've prescribed.
Yeah. Well, truth be told, this is a process that all of us are involved in. It's a team treatment perspective. And that's really a blessing. It's really nice. I hope that you all feel that to some degree you're being upheld as well, because you shouldn't have to solve all of the problems going on in that patient's world. They shouldn't fully be resting on your shoulders or on your desk whenever you come in or whatever. Like, it should be, you should be able to count on your team to be the faithful trooper in there, and to really to do their part to help the patient feel understood. The idea with this treatment is we have to deliver it in order to save their life. We have to get them through it. There are things that can be done. Mental health counselors and a nutritionist and things like that. They're there to bridge the gap so that you don't have to be solving 100% of the patient's problems all the time. It's just not fair. It's a burnout machine. If it was all on you, oh, good, you're drinking stuff too. Good. I'm going to start doing that. Fantastic. There we go. Cheers, everyone.
You have to stay hydrated.
I hope that the confidence I hope that you guys can have some confidence in the team that's around you, and finding a PT who's motivated. Like, I think I've astonished and probably disturbed some people with the level of motivation I have to make a difference to these patients. I really want the team around me to feel that they can count on me to go in and not to destroy that patient's confidence ever. I would break my heart, or to make them feel that they're not doing enough and that something bad is going to happen because of that. Those sorts of things are inappropriate for a kid to be feeling whenever they've got that much else going on in their world. The world's shattered, and my goal is to be in the room helping them put pieces back into place. That's what all of us should be doing. Chemo's part of that. Exercise and therapy and strengthening, what we kind of do with the sarcoma population, especially lower extremity sarcomas. It's akin to are you familiar with the adult world and prospective surveillance for breast cancer? Or any kind of, prospective surveillance is kind of, it's a catch-all for a lot of different things. In PT, what it means is that we surveil these kids early on and begin the process. The evaluation is just the beginning of the relationship. And we can then progress to, okay, we're seeing these impairments here, and you're obviously presenting with, maybe lots of swelling in your distal thigh, in that lower extremity area. You're not able to bend as well. It doesn't feel good to put weight through it. Well, that's your body telling you some things, and we can work around that. Here's what's coming, and knowing that you're going to have surgery. Here's how we prep for that. And right now you have enough stuff going on that we need to address some of these things before you get to surgery, so that you're not playing catch up later. And so whenever I have those conversations with a patient of any age, maybe not 3, I guess, but anywhere from 6 or older, maybe, is the age where I start having this conversation that says, I like you a lot right now. You have a lot going on in your life, but who you are, the things you're interested in, are so fun, and I value all of those things. I want those things to be present. I want you to like who you are on the other side of this, because someday this is going to be over. And I always, the older ones, I'm like, this is going to be in the rearview mirror eventually. And so I really want you to be happy with who you are, and, being being interested, maintaining the interest that you already have. And I talk about, if they talk to me about ballet or whatever else, or football or whatever else, my goal is always like, here are the things, like this is a series of problems between point A and point B for you. Eventually this thing is dealt with, the chemo is done. And at point B, I really want you to be happy with who that person is, with who you are. So can we prep a little bit? You may not have energy every day. And some days you may tell me to get the heck out of your room, and that's okay. But I want to be in your world because my goal is to help you reclaim everything from the jaws of cancer. So that's where we usually take the conversation. I have that conversation with them often, and on bad days, I reiterate it because I want them to know you've not lost anything. Like, this is not the end of the road today. And yes, we deal with parental expectations. I talk with them. Usually if the parent is right there and I can get a word in edgewise, my goal is always to encourage both the kid and the parent to enjoy things, to find things they enjoy together. And let me do some of the whip cracking and to talk about, here's the things we need to do. Yes, you can work on these at home. I think you should be able to choose when, and I think you should maybe be able to choose how often. But try to get it done at least twice, between now and the next time I see you or something, trying to make it about, here's some things you can choose about the process. And then to the parent, I say, this is a chance for them to take the responsibility of this. So don't feel bad if they don't do it all completely. This is training, and I don't expect them to get it the first time. So we just need to work patiently with this because we want them to be able to get through the process in the enormity of everything else going on.
Yeah, for sure. Go ahead, Lisa.
Oh yeah, I was just going to say, I think so many things you've highlighted are so important. And I keep coming back to what you said in the beginning about getting involved early, having physical therapy, because I think about so many of the adolescents and young adults that were treated, especially with sarcoma, who have either had a limb salvage or an amputation. And I see when they come back in long-term follow-up, they've had things that bother them for months, and they just keep on going with it and not asking for any help. It's like they just, or else then they just don't wear their oh my gosh, their artificial limb. I'm like, yeah. What's it called? Prosthetic. Yeah.
Absolutely. Yeah.
And it's just been crazy, the things I've seen, and especially the further they are out. And I think it's probably a combination of not wanting to go in because, of course, they have so much trauma from having cancer itself, and then having to go see your doctor if you don't need to just seems so painful to them. And then, but I think if they could establish that trust and that relationship with the physical therapist in the beginning, I think it would make it easier to even just reach out to them versus feeling like, oh gosh, I don't want to go back to the oncologist again, and I've seen so much struggle with that, with especially the young adults, the adolescents, because little kids, usually they probably have so much fun with you guys, and it's to them, it's not as heavy as it is for the AYAs. And so I don't know if you have any thoughts to say about that, but I think that's something I've seen a lot when I was practicing, for sure.
Absolutely. I would love to talk about it. I got to plug this in really quick. It's sure. Trying to die on you while we're talking. There we go.
All right.
Super good with technology. Don't tell anyone. Okay. So yes, with that. So honestly, having team members they can trust, obviously very crucial. And it's not just, a PT, it's prosthetists, and helping them, from navigating this world. They've never even heard of somebody probably who had an amputation. Like, most of them have never met another amputee their age, or something, And so knowing what the role of a PT is versus the role of a prosthetist and how they work together with each other, that's part of those educational conversations. And as soon as they have a face with it, it's a lot easier. If you're telling them about a certain person with a certain job, that's just glossed over. Like, they are literally 1,000 miles away whenever that conversation's happening. But if you drag somebody like me into the room, you're like, oh, this is PT Dan. And he's going to be like, they're like, oh, that's the weird gangly guy that's going to teach me how to walk again. Okay. Putting those pieces together helps them they don't know, but they're learning a different language. They're learning the language of navigating the medical system, and they're doing it at a young age. And so, coming up with oh, that's the person who, for very young amputees, this is the person who's going to get you your robot leg. And this is the person who's going to help you learn to walk again. And those things, like, it demystifies all of those processes for them. And then they just know, okay, that is connected to that person. And then it's much easier, especially for young ones, to associate it all. And the ability for everyone to establish that early on, I feel like, is very important. I want for them to know that they're not, it's not an afterthought, or that none of their desires, I want them to know that their values and their dreams matter to us. And for most of the kids who have that lower extremity sarcoma and have heard, oh yeah, I'm going to have a surgery and I might end up with my leg amputated, that kind of thing. The first thing they want to know is, when will I walk again? When will I run again? When can I do the things that kids all around me are doing? When will my world be whole again? So what I want for them is to know that it's just, this is having that team approach, having that perspective surveillance thing. We as a team, oncologists and PTs and everybody else, like, we can walk in and say, hey, there's a plan. This is how this works. Here's the people you need to know. These are your team, and your dreams matter. It's valuable.
And I think, above and beyond, I mean, obviously functionality is such an important goal and piece of physical therapy. And I think I've told Lisa this before. But I think what a lot of people might sort of miss in the physical therapy realm is that physical therapy often helps with pain also. Yes. Although therapy might be at times uncomfortable, not to the point of excruciating pain, hopefully, good PT, but at times it can be uncomfortable to challenge yourself. But, I was referred for PT because of a shoulder thing, and I sort of rolled my eyes and was a little bit peeved about it. I'm like, this is never going to work. And lo and behold, of course it did. Of course I felt better, and I've never had a problem with it since.
Yay.
What is I guess maybe just to talk a little bit about that, of how physical therapy can help manage, ease, and mitigate pain in the setting of cancer therapy and or surgery.
Yeah. Okay. That's a big one to unpack. Starting maybe by diagnosis. Let's try that. For a leukemia patient, for instance, we actually do a ton of pain stuff with them. There's lots of things that happen during induction because of the steroids and also because of the disease, that, leg pain is really common for the kids that I work with to stop walking if they're very young. The closer they are developmentally to gaining that walking ability, the sooner or the more likely they are to stop walking. There's a couple of techniques that I would say are not research-based at all. I've literally never seen anybody else do it, but it works, darn it. And I worked with a chronic pain specialist during my clinicals. I had 2 clinicals and have shadowed this guy extensively. He's one of my mentors, and he taught me several techniques, things for chest wall stuff. And a lot of kids getting portacaths get chest wall tightness and pain from that. And the portacath's going in, and we're also starting chemo, and there's leg pain and stuff. Lots of pain with a leukemia population in the first 3 weeks of treatment or whatever, So there's these deep pressure techniques that work really well for the kids with the bone pain. There's stretches for the pec stuff. And most of the time, those kids I often will try to show them how to do it themselves. And a lot of times they don't want to. They want me to do it for them, which is fine. I'm like, okay, but remember what we're doing here, because you can do this at the door frame. So I'll show them and I'll give them a little handout for it. But like, hey, I can also do it for you. I know it's scary to stretch around your port. So I love when I can be someone that they trust and to show them that they're put their trust in the right place and make it actually go away. So that's anyone getting vincristine, they can end up with leg cramps, pretty excruciating leg cramps, to be honest, like for some of them, and they just sort of tolerate it or live with it. And So in the process of that, sometimes just circling back and be like, one of the reasons this is happening, why these walk looks funny and everything else, these legs are cramping out of control. Do you have night pain? And they're like, oh yeah, every time like at night, I can't even hardly sleep. Well, gabapentin works wonders. PT can get in there and stretch them. And honestly, it's like a whole new person. So getting in and stretching calf muscles that are tight and cramping all the time is really valuable. Found a few that have actually cramped on the front side of their leg on the anterior tibialis area. So we, addressing some of that, you just have to go in and feel it out, because sometimes it's a mixed bag of presentation. You're like, oh, it's going to be calf cramps. I'll go in there. And I was like, the last little girl was like, you're cramping on both sides of your leg, girl. What's up with that? And she's like, yeah, it hurts right here. I'm like, that muscle's got a funny name. It's called anterior tibialis. They all sound like spells from Harry Potter, but teaching them about how to manage these things, like, okay, if they're got a sarcoma, well, some of the, if they're stuck in bed, or if they're stuck in a wheelchair, things like that, some of the things can hurt because of that. Their shoulders may get sore, or their backs may get sore, things like that. So we talk about, oh, you've got to get up. Getting up and moving is part of this investment. Yeah, it doesn't feel great, but it's the investment of keeping your body moving, because it's designed to move, and we need it to move sometimes, so that it just doesn't get the idea that it gets to sit around and complain all the time. Teaching, I always tell most of them, that your muscles are kind of like mischievous but loyal dogs. They'll try to protect you. They're also not very smart. I said all they know to do is to bark at you whenever they're angry. So we have to pet them and tell them that they're a good dog or a good muscle, and then we put them to bed, and they'll leave you alone after that. But we also have to walk them every once in a while to get them to move. And so I have these little stories that I tell the children. And one little 4-year-old patient here recently, I said, these muscles are angry at you, but they're trying to protect you. They just don't really know how to do it. And so they get to where they're barking so loud they can't really do anything. And I said, they're just like dumb dogs. But it's okay. They're nice. They just want to protect you. And she's 4, and she turned to her muscles, the ones on her shoulder that were bugging her, and she goes, shh, doggies, shh, doggies. And I said, it's okay. We'll calm them right down. And we did. But there's a lot of hypersensitivities after surgery. So, that enters a whole new realm. I feel like this is the rest of the podcast, gals. I'm sorry. But, like the hypersensitivities from nerve damage due to surgery or something like that. So figuring out ways to combat that, not just with manual therapy type pain relief massage or soft tissue mobilization, but also, okay, can we splint this if there's no movement to it? I've put people in braces because of Vincristine neuropathy at the same time that they had just had an amputation on the other side or something like that. It's just insane how much can happen all at once with the population. And in all of it, depending on the age of the kid and depending on their motivation, they just want to get back to normal. And so they're like, why is this happening? And who can demystify this for me? So I love being a part of that team where we can all of us kind of go, well, this is sort of why, and here's how we fix it. Then they drag PT Dan back into the room, and I love it. So.
Yeah, I think this is a very specific comment, but I sort of what I've noticed over, I don't know, the last couple of years or so is, we know that vincristine or vinca alkaloid neuropathy happens. I think the way I was taught about it in fellowship is different than what it actually is. And I think I was taught that it's always reversible and self-limited, and I found that to be not true. And so I much to like what Lisa was saying, I think there are some kids that are just like, well, I just have to live with this forever, and there's no way to mitigate this as I go forward. And so how often are you involved, or how often do you continue? You said you're seeing somebody that you've had for a long time. Survivorship population, I still see a lot of neuropathy. I still see a lot of fatigue, pain, cramping, things that are, activity limiting for these patients, where unfortunately it doesn't appear to be 100% reversible at that point. So what types of stuff do you do outside of like the active treatment, where it's really getting nitty gritty down and gnarly, but like now we're in like survivorship realm, and like, how do we optimize that to the best of our ability?
Yeah. Well, first of all, how fortunate your patients are that you are that astute to keep an eye on such things. And you've noticed this thing, because yes, you're definitely correct. And I think in the emerging research that I've read over the past 10, 15 years, everybody's sort of saying, I think what we've noticed in vinca alkaloids is that the nerve conduction velocity returns to normal, which seems like, okay, the nerve is normal now. But the presentation of that patient is not the same. It does not return to normal by itself. And so sometimes maybe that's gait abnormalities. A lot of times it's compensatory things that the person has done that have led them into this really faulty gait pattern. They never got stretched during getting vinca alkaloids. They maybe were not as active. They didn't know that they were starting to walk funny, and they kind of continued it all throughout. Or maybe they just never had a balance situation occur that was so blatant, that so attacked the one weakness that they really have with neuropathy, which is usually Achilles heel tightness or something like that. That's usually what I see. So long-term follow-up, yeah, 100%. I mean, there's so many of them. I mean, most of the people, if I had them all on my computer right now, I would show you. I have like 15 different videos of kids who never got PT that I've seen in long-term follow-up that have progressed. They're off treatment and they are having knee pain because of the way they walk, and they're having and they don't understand why they can't bend down without falling over, kind of thing. And they're tight, and it's not so pathological, and their strength even returned. You're like, oh yeah, their strength's great. Well, but their dorsiflexion range of motion is really only about 10 degrees. They can't pull their foot up or less. Maybe it's like 5 or 0, and they can't pull their foot up when they walk. So they trip all the time, or they step. They have the steppage gait pattern, which is where you like bring your knees up too high when you walk, and that poor foot clearance is gonna bite them eventually. And so one of the things that I've encountered a lot is that most of them, and this should be probably a litmus test for these kids. Eventually I'll, get a research study and publish it. But the PT Dan test, can you squat down and stand back up again? Most of the ones who have had this and have never had it addressed, they can't squat. They can't fully squat without, they basically usually fall over. And they don't realize that they can't do it because very rarely do they squat all the way down. But it's there because of the neuropathy, and it's just sticking. It's sticking in there. And so some of it, I think, is learned habits, and some of it's tissue changes. But you're right; it's definitely not. It does not. It's reversible. Yes, the DMG shows that it's reversible, and it improves and stuff. But the residual and even the pain complaints that some people have are out of the realm of what should be possible, given that the nerve is repaired. Right. So.
Right.
Yeah, I think it's bears further consideration in research, but I think that what they've discovered so far, at least identifying it, the PTs are there's the best childhood cancer research PT related stuff. I mean, the largest body of it is on trying to address these issues and trying to detect it and then fix it. And that's what my research is centered on too. So.
Lisa knows that's my favorite question, is what's the next thing in your field for research? What's up and coming?
Yeah.
I have a suspicion that, and this is probably in Lisa's husband's realm, of these sort of long-term kind of, I guess, limiting situations is, what is going forward for physical therapy research, and do you see any role for regenerative medicine in the future? And I say Lisa's husband because he's a regenerative medicine doctor. So it all is related.
That's a good question. I will tell you, I don't know as much about the different charges of regenerative medicine, where they're headed with that these days, but I bet your husband knows. I'm good friends with the director of regenerative medicine here, but I honestly have to be honest, I don't know what they do. So I do know that emerging field-wise, from a PT standpoint and pediatric oncology especially, there are lots of people trying to solve the physical activity problem. And I think that's becoming, I think that we're kind of beating our heads against the wall with it, to be honest. like everybody wants to do my favorite study to pick on is the let's slap an activity tracker on the patient study. Oh, and let's combine it with Pokemon Go, or let's combine it with some kind of a leaderboard so they can compete against their peers with their physical activity. I think that will work with about 35% of the population. And I think that it won't work with the others because none of those things really take into account the needs of that child. What we really need is a solid team who communicates well and a chance to circle back to a PT who has a broad knowledge of, oh, this is what you're into, but have you tried this thing? Because it's very similar. And it would be easier. We're given, with all of your cancer treatment, what sort of things we're dealing with. So given the problems and the outstanding, what is it, Michael Stubblefield that says, given the parameters that cancer treatment and cancer have placed on your body, this is your optimal level of functioning. So that's what I would say is, helping somebody shift gears and change maybe the color of what they thought they were going to do. That's how you address the physical activity thing. So in my opinion, somebody will be like, oh yeah, they actually do really, really well if they check in with a PT once a year or something like that. But the thing that I'm researching right now is a way to detect, I don't know, I think I'm allowed to talk about it. I think so. Anyway, it's a way to detect chemotherapy-induced peripheral neuropathy in children who are too young to describe their symptoms or are nonverbal, because there's seems to be a gap, at least somewhat of a gap. And parent report is one thing; it's important, and we use that in the metric that I developed with my team. And so what we're trying to do is just kind of see, okay, well, we know what neuropathy looks like whenever we see it clinically, so trying to combine all those things in a way that a toddler can do it is the name of the game. So this study is ongoing. I think it's due to close at the end of the summer here or in the fall. So that's the other thing. And so with that, they're trying to demystify some of that. Okay, if you see these types of gait mechanics, and even all of my oncologist friends know this stuff too, like when you see this kind of thing happening, I can't do the whole heel walk thing anymore. You start to wonder and things like that. So, but everybody sort of knows those hallmark questions. So anyway, trying to make sure that that's like a gold standard or okay, this is what we do for every one of those kids then when we see it.
Yeah. And I've worked at 2 places now. Lisa, maybe you can tell me what you did in Arizona, but I've always thought this, and those vinca alkaloid heavy regimens like Rhabdo and Wilms.
Yeah.
We all know it's coming,
Mm-hmm.
but right now our practice is not to do, we do physical therapy preemptively, but we don't start gabapentin preemptively, like those sorts of things. So I've always wondered, like I know this is going to happen by week 7.
Sure.
Like I know your reflexes are going to go out. I know you're going to stop. You're going to start toe walking. I just feel like maybe there's a better way. I don't know. What did you guys do, Lisa?
Oh yeah, no, I think part of the problem is that we lack the resources in Tucson. We lacked being able to have physical therapists come every day, and I think that's part of it too. But yeah, I think just like what Dan is saying too, we need like the prophylaxis first, or to be able to start early and see how can we combine medicine with the physical activity and everything else to optimize for that patient. And I just think everything you highlighted on, Dan, for optimizing for that specific patient, because we've done plenty of studies that show that wearing a tracker isn't going to fix everything. I mean, yeah, and I think we should definitely have you on again, because I think there's so much we didn't even get to today, because it's just amazing all the things that you're doing, and it's really exciting to hear your research too, because for those patients who are too young to tell us, it's so important. Yeah.
Yeah, I hope we get good data. Otherwise, I won't be talking about it much, I suppose.
There is data to be gotten for sure.
Yeah.
One thing, if there's any time left, and I don't know how you guys would normally close the shows, but what sorts of things, having listened to me drone on for quite a while, you guys you enter this from a different perspective than I do. And I've always been curious, what sorts of things are helpful to you when you think about physical therapy and that sort of thing? What's the wish list from an oncologist for a PT who's entering into the population that you're treating, who's entering onto your team. Like, what sorts of things do you guys want, and what do you look for? What are the kinds of things that make that a meaningful contribution to you?
Well, I mean, I think I'll let Wendy answer this as well, but definitely it's just all the things you said for being able to bond and relate and to that specific patient, to be able to motivate them to want to engage in activity that's fun, because I think so much of it is that doing exactly what you're doing. Like, you have to tailor it toward that patient so that way they're motivated and their parents understand also why it's so important. But go ahead, Wendy, you too.
Yeah, I think, obviously cancer care is a team sport for sure.
Mm-hmm.
And part of what I look for in my teammates or my team members is, just as I try to learn about, physical therapy, I joke about it being a black box, but, I do try to learn about it. I think it's the most meaningful collaborations or teamwork is when everybody has at least a general understanding of the disease course and its treatment and sort of where we're at. So like, that's all through experience and learning. And, at this point in your career, like week 12 is when we're going to start doing local control and, all of those things. And just understanding overall the prognosis and where we're headed with this particular patient that helps us set those goals for them, right? So I think that's important, so that the goals are aligned with the therapy, the goals are aligned with prognosis, and the goals are aligned with family values and personal values. I think those are the most important things. Things I hope that we sort of get to in the future goes back to that kind of like activity trackers don't solve everything. And I think there's up and coming data that physical activity and, increasing oxygen delivery is probably helpful in an anti-tumor fashion. And like, I think there's so much to be done. And I would really love to see more partnerships with, outcomes research and anti-cancer research, partnering with our PT partners and our OT and those sorts of things, so that we can do that really high level or, deep dive into what does that physical activity look like for functional outcomes, patient reported outcomes, and tumor outcomes. Absolutely. And what are we doing to the tumor microenvironment, all those things. And I think,
absolutely.
I think we need more people thinking in that way to make it happen better. I think it's ongoing in little pockets, probably places, that have more resources like the St. Jude's and Seattle Children's and things like that. But it's going to take more. And so that's what I hope is in the future.
Yeah. My, an oncologist I work with here was MD Anderson trained, and that was something too. I mean, she just gave a mic drop of a presentation about, it was literally called How Not to Cure Childhood Cancer. And it was talking about tumor microenvironment and changes with exercise versus not exercising, and nutritional changes and things like that. So I feel very tucked in here. I have a wonderful team of people who really get that stuff and really want to see long-term survivors thrive better than they have, not just surviving it, but, having something to say to the world about cancer once you get out of there, not just surviving and limping along. So,
and June is Survivor Month. So
there you go. Yeah.
There you go. Perfect way to end. But I think there's a lot going on. I think a lot more needs to be done. And I'm really grateful for my team here. I think a lot of our rotation plasties end up back with you. I think we share surgeons. It takes a whole team for sure.
Yeah. That's right. You are at Mayo. I just now looked down. I'm so sorry. I've been this whole time wondering about that.
I'm actually in the basement right now. So how would you know?
So that's really cool. I kind of wish we could have talked about that. There's apparently you have a PT Ben that works with you guys there.
We have a PT Ben, and when you were talking, I was thinking of a story with a little girl who had neuroblastoma, and I was in there talking with her, and PT Ben came in. She's like, "Excuse me, I gotta go." I rolled out with PT Ben, and I was like, "Wow,
nice,
cool."
Well, it's nice to be.
Liver.
That was a quick handoff from team member to team member. Nothing awkward there.
They gotta go. They have things to do. They have a game to play.
I have I love that though, because then it's for them, it's fun because it's like they're hanging out with different members of the family and they're like, well, I'm just going to go over here now with this person. So
Yep,
I
exactly.
love that. Yeah, I've heard of PT Ben. I've heard from patients that PT Ben is like, yeah, the only reason I'm PT Ben is because PT Dan apparently. So like, I know people have been calling me PT Dan for a while. So, well, thank you so much for having me on, gals. What a wonderful way to talk to each other and to meet sort of in person and stuff. I'm very, very thankful for the time.
Thank you for joining us. This was great. I'm sure we'll have lots of follow-up comments and questions.
That sounds good. And I would love to talk more about any of it.
And we'll
stop talking is the biggest challenge. So
no, it's so great. And we'll definitely put links to your social media. And I saw that you have YouTube videos talking to your former patients or people in survivorship about rotationplasty and everything.
You probably know that patient, I suppose. If you're at Mayo, you probably know the gal who did the rotationplasty videos with me. She's quite famous around your area.
Nice.
But yeah, so we do rotationplasty education. I mostly make those videos whenever there's a need. For one of my patients has a need. I need to make one here coming up soon where Carl, the IV pole. Have you seen any of these videos? They're all kind of silly and they're getting sillier.
They're amazing.
Though Carl, the IV pole, needs to go fishing is what I was told by one of my patients. So that's going to happen in the next video. But usually it's either sometimes just to make them laugh like that or to express value to them, but then also just to sometimes demystify something like rotationplasty. So it's a scary surgery until you've seen somebody with it. So that's what we did. We made a video.
That's awesome. Well, thank you so much, Dan, PT Dan. It was so great talking with you. We really appreciate having you today.
It's wonderful to talk with you all. Thank you for meeting with me.